rotate it all that much. But what we do need to correct right away is the tube angle. Okay, it's not angled enough. Usually 5 to 7 degrees is what you have to use on just about everybody. Most of the times I use 7 degrees. If they're really skinny, then typically you don't need to angle as much because they don't have as much muscle. It's kind of bringing their leg away from the table. Right? But generally 7 degrees goes cephalic. If you use that, you won't have to worry about these two lines hardly ever. Okay? Rotation should be really the only thing you're trying to fix. Now if I'm looking at this, I'm looking and say, okay, it's a little rotated. Obviously I corrected my angle, but I still have to correct my rotation. See how the fibula right here is almost out all by itself? Okay? That means your knee is too far down towards the table. The heel is up too high. Okay? Because if you put your finger on the fibular head and you raise the knee up or raise the heel up, what happens? It starts to come posteriorly. Okay? If it comes posteriorly like what it's doing here, it's going to eventually come out all by itself. Okay? So you just need to understand the relationship between the fibular head and the heel. If you rotate the heel down, what happens? Fibular head goes which way? Forward or backward? Forward. Okay, so it goes forward, which means it's going to be more superimposed underneath the tibia here. Okay, so when you're doing your rotations around the room, look at the skeleton, see where it is, and see what happens when you rotate the heel up and down, which way the fibula goes. Okay. This view here, AP, okay, a little bit shifted off to the side, but still have the superposition along the fibula here. Condyles look about even here. Okay, long axis you always want going down the middle of the leg here. So if they're on the table and you like move them over this way, make sure you adjust the tube heads so that the long axis is still going femur connecting all the way down to the tibia. Okay.
Lateral.
Lateral, okay, what's wrong with it?
The rotation.
Rotation, okay. These two lines right here are off, okay. These two lines, this line and this line, are actually on the same plane, okay. So one's not higher than the other. On this condyle, you see the roundness of this condyle, so the bottom part of that and the bottom part of this, these are on the same line going this way, okay. So there's no tube angle problem on there. What'll happen is that these will be superimposed if you correct the rotation, okay. Adductor tubercle, right here, okay, a little bit thicker here, a little bit more white. This part right here, see how clean that line is? No adductor tubercle. You know that's the lateral part of the femur on that, okay? Because the medial border has that little bump or adductor tubercle on there, okay? This right here, completely out by itself, okay? That means if I'm looking at this left leg like this, that means the heel is way up too high, okay? If the heel's up too high like that, this fibula is going to come out like that, okay? So all you need to do to correct that is bring the heel down. That's going to rotate everything forward. This is going to go more anterior. That's going to correct this rotation right here, okay? So that it will be superimposed underneath here. Mike, this view? Kind of, it's a specific view. Tunnel view here, okay? It's going to look like the AP, but you're going to see the roundness of the tunnel here. This one is slightly rotated. You see this extra little bone right here? Okay, it's not perfectly straight. Okay, so it's going to interfere with that tunnel a little bit. You can still see that kind of hole or tunnel being formed there, but because it is rotated slightly, it's going to kind of interfere with that. You're not going to see a clear tunnel all the way throughout. Megan?
Internal oblique. Internal oblique.
Yes. Internal oblique, okay. Fibula starting to come out by itself. Some people it doesn't come out all the way like this, or this one isn't out all the way, but it doesn't come out completely. Big key here, patella shifted off to one side of the condyle. Okay, condyles look a little bit misshapen. You see the whole roundness of this condyle. This condyle is kind of tucking in behind itself. Okay, so this is a medial or internal oblique of the right knee. Okay. This, obviously bilateral tunnel views, okay? You see the roundness of the tunnels being formed here. See the difference between this and this, okay? This one's straight on, no rotation in the knee. Okay? This one, slight rotation, interfering with the space here. Okay? You can do these both at the same time. Some techs like to do them up against the wall bucky, bend the knee in, put a slight angle on it. It's probably how they got this view on here. Not ideal, but if you want to get it quick and fast, get it out of the way, then you can do it that way, especially in orthopedics. This view here, this is a good lateral, okay? See the condyles, these two condyles at the inferior border, these are superimposed pretty much. There's a slight difference in the horizontal lines here, but basically I would consider this superimposed. On the back, almost no rotation at all. You can see the separation of two lines there, but it's very, very slight. This is more than an acceptable image. Ideally, if you want it perfect, it would be right on top of each other. The book has some demonstrations of that. PowerPoint also has like what'll look like just one condyle. If it looks like one condyle, then you've got it perfectly superimposed. Okay? So you see two different lines and it's slightly askew. Okay? Sesamoid bone there, okay? Bigger, more popular sesamoid bone in front here. Okay? Because you're putting a little bit of a bend in the knee, there's always room in front of the tibial tuberosity to put your marker on. Okay? So make sure your marker is in this area. You feel on the front, you can feel the bone right there. There's not a whole lot of muscle or tissue in front of that. So if you put it right up against it, it'll be in your image, but it won't be underneath it. Okay, it won't be superimposing anything. Okay. This one, in addition to being too dark, okay, there's another lateral that you can clearly see the two condyles here. See where the fibular head is? Normally the fibular head, and it's going to change. Usually this is tucked in a little bit more for most people. But if it's tucked in all the way in this way, okay, how do we get that fibular head in all the way that way? If it's a left knee, if we bring, this is my bucky over here, this one is going to be the heel is too far down. Okay. Now if you put the heel down against the table, the fibular head is going to come underneath the tibia. Okay. If it's underneath the tibia like that, it's going to be completely superimposed. You're not going to see any of it at all. What that's also going to do is that's going to bring your medial condyle back. Okay. When you bring the medial condyle back, you see the adductor tubercle stick out all by itself right in here. Okay. If that tubercle is out posteriorly, then you probably need to just raise the heel up a little bit. That'll bring this back, and it'll tuck this behind, and then you'll get a little bit more superimposed here. Okay. Let's see. This one, tunnel view here. See the tunnel being formed there, a little bit distorted. See a little bit of a growth plate right here. Okay, there are growth plates at the ends of the tib and fib, as well as the femur. It's a little bit higher, but this one you can clearly see here a little bit. Merchant view. Okay, what we're doing on this tangential view is just trying to get the kneecaps out by themselves. See the little kind of fossa being formed here with the distal part of the femurs. It should be out up and above there. Got a little spurring right here on the end. They do these comparatively so they can see, if one is in its normal position. Because if you see something like this, you think, well, that's a little bit to the outside. But this one's actually normal. This one's sublux a little bit down into the space and a little bit more posterior. So it might be a ligament problem pulling it out that way, or it might just be a lack of space between the patella and the distal femur. So here, problem should be obvious. Okay, obviously it's rotation or dislocated and rotated. Right? Okay. Knee is not supposed to be here. Knee is supposed to be up here. This right here is the patella sticking out all by itself. Okay? It's not a fragment. Patella is supposed to be in front with this aligned more in line with the lower leg here. Okay? So cross table lateral done. You see XTC, cross XT, cross table, not C, but L, lateral, XTL I should say. So it's done this way. You're obviously going to see a huge skin bump right up here where this leg is, and then a corresponding one down here, and then you have to open it up a little bit more to get it on there. This view here, tunnel view, okay. What's 11? Intercondylar, eminence, okay. Tibial spines, okay. There's a few different names for that. Make sure you know at least one of them really well. And this right here, between the fossa, intercondylar fossa. Okay. There's a little tunnel being formed there. Okay. This view here, AP knee. Okay. Which knee? Right knee. Okay. It's hung correctly. Okay. So make sure anatomically you know how these look. The laterals, I'm not gonna ask you if this is right or left, okay, because different techs hang them different ways, but the internal obliques, the tunnels, PAs, you should be able to figure out if that's right or left, okay, just anatomically. Just think where the fibulas are. Fibulas are the outside, they're facing you, is on the right, on my right. If I'm facing this way, then it's going to obviously be the right leg, okay? Left leg, it'll be on the left side. Right here, see these little lines right here? Okay, the closer you get, the easier it is to see them. With all these lines here, these are grid lines, okay? So, if you see a whole bunch of lines going across, grid's not moving, or your grid is off center if you're doing a cross table lateral from whatever, okay? You shouldn't see grid lines. If you do, then something's not working correctly.